Hello, my name's Professor Chris Fox, and I'm an old age psychiatrist working in the NHS, and I'm a clinical academic. Today, I want to talk to you about sleep disorders in primary care and initial progress with our project called TIMES, which is a 5-year program exploring sleep disorders in MCI and dementia. We know that sleep problems are very common. Approximately 26% of people living at home report sleep problems if they have dementia. Almost half of people in care homes have difficulties. And in mild cognitive impairment, the range is much broader. Part of this is because of lack of research, definition of MCI, and size and sampling of the MCI studies. We know that dementia is increasing despite breakthroughs, but sleep remains one of those targets. It has great potential as a modifiable risk factor in people with dementia and their progression, but also preventing people with mild cognitive impairment converting to dementia. Current approaches to assess and manage in primary care are problematic. There's a lack of training with staff within the UK. Undergraduate doctors only getting 1 hour of sleep training in their entire course, and postgraduate courses are also limited. So in our first part, we want to talk about how we aim to address the issues of challenging and delivering tailored care for sleep problems in 2 groups of patients, people with dementia and those with mild cognitive impairment. So the first part of the research has been a realist review. I'm going to provide some of those results today. A realist review is used when an intervention is very much dependent on content, and also published evidence is difficult to elucidate or not exactly relevant. So we have to go to other forms of literature as well as consensus views to try and shape realist reviews. The key thing is to develop a theory using context, mechanism, and outcome of how things are working or not working and how processes occur. It has a wide search term and has broad inclusion criteria. Here are some of our results. We screened 1,869 documents identified, 1,409 were screened, and 60 were included. And as you can see, moving from left to right, in the context, there appears to be limited awareness of sleep difficulties. Clinicians are under time pressure. People with dementia don't remember to talk about their sleep problems, they have to be prompted, and even then give inaccurate reporting. Often we have to rely on family members who will notice. Multimorbidities are also very, very common in people with dementia and can impact on sleep, but also overshadow the conversation and consultation. Sleep disorders also remain untreated for long periods of time in primary care. The other aspects and mechanisms of a list here we've developed. Coping strategies are developed by patients and families. Sleep disorders are normalized amongst families as well, as nothing can be done. And clinicians lack confidence to treat. There are concerns about overuse of medication. And also, it's not regarded as a serious problem by clinicians or potentially carers, despite the potential benefits of if you sleep well, then you feel stronger, you fall less. It can affect your physical condition, but also it can have a major impact on the carer, who then is better able to care for them rather than caring in it from a tired perspective. In addition, if for younger onset dementias, inability to sleep affects their ability to maintain their position in the workplace. And the outcomes we found were that sleep disorders are often not discussed, investigated, or indicated. If you ask, it emerges. But in the time-limited assessments that primary care have, it often is not asked, and it requires prompting as one of our conclusions. So to look at some other aspects of context mechanism outcomes, a lack of awareness has indicated patients and with dementia and MCI often on long-term usage of drugs to manage sleep disorders with no apparent review and no consideration that they're no longer effective. There are time resources both for paid carers and clinicians, and resource restraints. What can you do? People also with dementia and MCI may be perceived as having limited life expectancy. The mechanisms for some of these things, as indicated on the slide, so clinicians looking at sleep disorders and interventions often feel medication is the only option. Sometimes this is inappropriate. Regarding long-term use of drugs, families and doctors fear if they stop the drugs, there'll be a relapse and that'll cause more problems. Clinicians also feel pressure to provide a one-stop shop, quick solution. Prescription is relatively easy. And carers also demand and quite rightly want an easy way. And if there is nothing else, then it can be appropriate to prescribe medication under certain circumstances. Clinicians also often overlook the side effects in favour of improved sleep. Also, there's a lack of review. So moving on to the qualitative aspects, which we will cover today. So we've undertaken observation work in GP surgeries, care homes. We've undertaken staff interviews and also listened and observed telephone consultations with patients, families, carers and care home staff. And to present some of the results of this today. The emerging findings appear to be, if we look at the literature on the left and observations on the right, concordance. So first part is GPs have limited time and often focus on physical assessments and overlook sleep problems. However, other roles can provide that if needed. There are other members of the primary care team who could reduce the time required by the GP and better bring information to the consultation. People with dementia have limited awareness of sleep problems and are less likely to discuss these problems with their GP. And carers raise concerns of disturbances as these are a major burden for the carer. Medication is often the first choice for sleep disturbance and are prescribed chronically and inappropriately. And clinicians are describing a growing movement towards deprescribing and trying to develop more contextual understanding, but with limited tools. Get further observations versus literature concordance. Again, primary care have limited knowledge. Sleep disturbance seem to be symptomatic of wider issues such as pain or stress. Once these explanations are eliminated, patients are often referred to specialist sleep services. Care homes are understaffed, limited resources, and as we move towards deprescribing, we must develop better interventions in care homes. And there's a high burden on unpaid carers, leading to care home breakdown and change of placement, such as hospitalisation and need to placement in care homes, which could be avoided if sleep is better managed early on. So in Times, we've developed a prototype intervention, which we'll be trialling in 2024. It consists of three components. First of all, a so-called onboarding tool or assessment in context, which will provide prompts and questions for the patient, family members, which would then provide information which can be filtered and presented to the GP. So when there is a consultation or another member of the primary care team, they have that information to hand, which can make the assessment more efficient, but also bring up issues which the GP may not have thought about, or primary care member of staff, such as not being able to sleep with one's partner, poor quality sleep, or snoring. All of these are suggestive of significant issues which can be managed. Then there is a consultation and a co-creation of a treatment plan. And the key thing in our intervention is going to be a review, not just a one-stop shop. And that review will be set according to what the plan decides. It may be a month, maybe 6 weeks, it may be 3 months. And the nature of the review might be email, text, face-to-face, or a telephone call, depending on the nature of the problem. This is the prototype we're going to be trying to see if we can improve the management and assessment of sleep disorders in patients in care homes, in patients with dementia, and in people with mild cognitive impairment. So our recommendations are, there is currently no tailored care for management of primary care sleep disorders in people with dementia and MCI. This also comes into secondary care and specialist mental health services. There is awareness of the importance of sleep problems, but a feeling of potential apathy sometimes apart from medication and what to do. Deprescribing needs to be encouraged, and care homes need better training and staff to support sleep management, which is very common. There's also potentially a role for technology which would fit into care homes, which can help with monitoring of and description of the nature of the problem. Thank you for listening. I'm grateful to my team members and the funder for supporting us.